So I'm Neal Kleiman at the Houston Methodist Hospital, and it's my absolute pleasure to be here this morning with my longtime friend and colleague, Dr. Morton Kern. Mort and I have known each other for 30 years, and during this time I continue to learn from Mort at an incredible rate. Every time I meet or hear Mort, I walk away a smarter human being. So if you would like to learn coronary physiology, at the risk of sounding a little self-serving, I really would suggest that you tune in to the DICET channel to hear Mort's most recent lecture on coronary physiology, which was just given. It was absolutely fantastic, and it will be available January 26th. So if you know how to use YouTube, find the DICET channel and look for Dr. Kern. So Mort, welcome. It's been a blast having you here. As I've said, I always learn when I listen to you. Every time I think I know everything, you make me very humble and remind me that I know nothing.
Well,
so Mort, I think you're the person who knows the most in the world about coronary physiology. Tell us how you got interested in it and how you followed it through the years.
okay, Neal, thank you for saying that. I am certainly not the person that knows the most in the world. I'm learning about this myself from everybody. Here in Houston, Land School, Niels Johnson are continuing to educate me on the subject. However, you did ask how I became interested. And it's a good story because I started off as a fellow at the Brigham with Bill Grossman, who assigned me to a project of measuring coronary blood flow with a thermal dilution catheter and cold pressor testing. And
in the coronary sinus.
In the coronary sinus, coronary thermal dilution, so indirect measurement of LV flow. It was inaccurate, but at least we had something. I took a real liking to making measurements. I loved the Cath lab, I found. Cold pressor testing was incredibly difficult and interesting at the same time. But I started to learn about coronary physiology. I liked it. I continued. I took my first faculty job in San Antonio where I wanted to learn about Doppler flow because there was a man named Kent Richards who had developed a Sones catheter with a Doppler on it. Fortunately, that catheter never became available, and I continued to do thermal dilution for another 3 years of blood flow measurements, and then a Doppler angioplasty catheter was developed. Subsequently, a Doppler guide wire came to my lab in St. Louis fortuitously, and we started to measure coronary blood flow in every kind of patient everywhere. And the more measurements we made, the more I had to learn, and the more I had to learn, there was more questions asked. And then we had a pressure wire. So having pressure and flow measurements in the human coronary circulation in the lab became a wonderful opportunity to study and start to explain things, and then see if we could make it a practical measurement for use in everyday practice. And that's where FFR and its building, development, studies, outcomes, and applications sort of caught my attention, and has kept it over the course of my interventional career.
So we talked a little bit about why FFR measurements underused. Let me ask you this, and I'm asking you to be judgmental. Why do you think most of us don't know very much about coronary physiology anymore? And I include myself among the guilty.
So the truth is we are an image-driven specialty. We're brought up as imagers, we're brought up with emphasis on angiography, we're brought up with decision-making based on the images alone for the most part. We use non-invasive modalities when they suit our preconceived notions of what should be happening to the patient, and we discard them when they're not. And we've not adopted it, at least in our training, the senior guys at our level, and maybe a few years behind us, senior guys at our level have not overwhelmingly adopted the physiologic approach, even though now it's going on 2 decades. I think the younger interventionalists have a better appreciation for it.
Well, I don't doubt that they have a better appreciation for the utility of FFR. I'm more concerned about their understanding of why it works.
So this requires a little bit of specialized study, as it does for understanding echoes. Doppler flows across valves, Doppler flows through the heart. I mean, they need to understand a little more physics, pressure flow relationships, and so on. Otherwise, they have a very cursory understanding of some of the echo information. Same thing with coronary physiology. It does require a little separate study, dedication to that. And hemodynamics are much less emphasized than they were in our day of early training. Part of the reason that FFR is not universally practiced or adopted in practices are things that you had mentioned earlier. It's time consuming, it may be confusing, they don't trust the data because of this inability to overcome the visual functional mismatch concept.
So do you think that's biologic? You think we're really driven by our visual cortex more
I do.
than our ability to reason?
Yes, I do. I mean, even after all the time I've spent making measurements, I still am disturbed when I see a lesion that doesn't match up with my expectations. I understand it and I accept it, but I am disturbed by it. And others are even more disturbed by it. And we are an imaging-based specialty, and we work in that sphere. And almost anything else is beyond our appreciation. And there is a limited amount of time that we have to devote to understanding these new concepts. Now, FFR is not new, and FFR data is strong, and its outcome data is strong. But just by the fact that there's another measurement introduced where you can simplify, that's what the interventionists would like. They'd like to have the most simple measurement, quickest, easiest, and let me get on with the job I like to do, which is delivering stents, making arteries better, making patients feel better. So it's intrinsic, inherent in our behaviors. If I could measure FFR, vessel size, amount of plaque, distribution of plaque, composition of plaque with one tool, that tool would be used all the time, I think. Because it would give us a lot more information than the angiogram. Right now we have 3 or 4 different tools to get all that information, and we don't have time or energy or understanding to apply them all. That's pretty much my take on it. Of all of those tools though, FFR is among the easiest and best data supported method.
So let's shift gears. You've been a pioneer in interventional cardiology. Now you're a chief of medicine.
Yes.
Tell us what that transition has been like.
It's been challenging and interesting. So at my institution, I was chief of cardiology at the VA Long Beach for a number of years. And as leadership changed above me, they wanted to fill this position. And they asked if I would become chief of medicine because I did a good job with cardiology, the cardiology section. Initially I said no. I said I am very happy to remain as an interventional cardiologist and chief of cardiology, but I don't want to have my life run by some other specialist. A GI specialist was brought up. So I knew that eventually I'm going to have to evolve out of the cath lab and evolve out of my current intense applications of cardiology as I get older. And I said this would be a good for the institution, good for cardiology, and good for me. It would bring some new challenge, and it wouldn't interfere too much. So I took on this transition to chief of medicine, and it's been enlightening. I did give up STEMI call. That was that difficult to do.
I'm sure that was heartbreaking.
It was tragic, but it was wonderful. My wife really thanked me for it and appreciated it. So I became this chief of medicine, and now I have, instead of one cardiology group to run, I have the cardiology group plus 10 other sections. But the problems are similar. Physicians have similar complaints, similar needs, similar kinds of desires. I don't have to be a specialist in rheumatology to be able to answer the questions of my rheumatology faculty. I don't need to know about the different types of bacteria that my ID guys are struggling with. I just need to get them an office. I don't need to have intimate knowledge of the GI tract as long as I got somebody to put a scope down and I give them a place to do it. So it's an administrative role which I find satisfying. If I don't do it, somebody else will do it to me, and I'd rather be the on top than on the bottom.
Tell us, how much has that taken away from your ability to be a cardiologist and to do the cardiology things that you still want to do?
So there is some transition involved. So I'm not as involved in the cath lab as I was. So I'm only in the cath lab 1 day a week. I don't do the highest risk cases that I used to do. I still do most everything during the day. We do high risk, we do some impella, but I do recognize the fact that I'd like my younger colleague to take on the highest activity level, in part because I'm not in the lab every day, and I don't feel as completely comfortable with all of my skills as I did. The other is I don't have the same time allotment, and so that's limited that capacity. And you know, I'm still at cardiology conferences every week. I'm still teaching the fellows. I still make rounds in our coronary and our cardiology service occasionally. It is a transition out of cardiology. I don't feel any less. I still write for the Cath Lab Digest every month. I still am in intimate communication with all my colleagues through our listserv. I still review journal articles and write editorials. I'm part of the research group, but I'm not doing any original research. And the handbooks are still being produced, and this will probably be among the last cycles of those books, at least coming from me. I've now identified some wonderful young co-authors, co-editors to take over the job. But the transition to a different life is an uncomfortable experience, and I've sort of done it in steps. I transitioned from university practice to a private practice when we moved to California in 2005. That was a shock to go from academic practice to private practice. I was only in private practice for 18 months, and then the university persuaded me to come back. It didn't take much persuasion. Coming back into academic practice, I recognized that, you know, I was much better suited. It was something I enjoyed much more. But it was part of a transition, and I knew that eventually down the line, maybe 10 years from that time on, I would have to transition out of the intense interventional world that I was in, and maybe even transition out of cardiology altogether, depending on what status I had 10 or 15 years down the road. Health status, mental status, family status, retirement needs. You know, as a senior cardiologist, I never thought I would be a senior cardiologist. Here I am.
Well, it's still hard to think that way.
It is.
But you're a guy who's got a lot of perspective. Tell me how you think we ought to change, at least in an ideal world, the way we train our fellows.
Wow, big question. So I was just looking at one of the editorials written by the fellows in JACC this week, and they talked about block training experience. So I don't like the method.
Is that our fellow that wrote it?
It could be.
Maybe.
Yeah, it was very good, and I think he's correct. The block training method said you learn more by doing a series of procedural activities close together rather than doing them spread out individually over time with big gaps. That is, if I do 8 TAVRs in 2 months, it's a different experience than I do 8 TAVRs spread out over 2 years. So I think that block training methodology should be reinstituted. We used to have such a program when we had fewer blocks. I think concentration in certain areas for periods of time would help. So a reshaping of the fellowship training exposure. I think that earlier identification of the needs and wants of the fellows, because there's such subspecialization within cardiology, would also be helpful from an early career. That is, a sampling of the different areas in the first year, which would help the fellows focus their attention in the next 2 years, might be also something to do. Some guys are not going to do invasive work. Do we have to force them into doing 4 months of cath lab work? Some guys are not going to want to do much nuclear or whatever special electrophysiology. So not everybody needs to do everything now that there are identified extended training pathways.
Of course, the other side of that is I never thought I'd really have to learn to read transesophageal echo, but as things have evolved and now that we're doing mitral valve interventions, I've got to have some skill at that. And
Yes.
That's been, at least for an older guy, that's been very difficult to go back and relearn.
Yeah, so that is...
So they've got to have something.
Oh, yeah, no, I think they need to have exposure to everything. The question is, if they know they're going to be going down the structural pathway, at the end of their first year, they could say, well, in this path, I need to be good in the cath lab, and I need to have good imaging, but I don't need nuclear, I don't need EP, I don't need as much heart failure management specialization rotations.
But remember, not too long ago, there was no structural pathway.
Correct.
And people who really didn't imagine that there would be are now leading structural interventionalists.
Correct.
So they've had to learn something that was completely remote for a long period of time.
So without knowing what the future is going to hold, I mean, right now you're asking me how I would change it for what
Right.
I see, and that's what I see. Did I have to learn new skills as I grew up? We all did, right? There are many things that we're doing now that we didn't do before. We learned how to do different interventions. We learned how to do different measurements. We learned how to manage sick patients differently and new devices. So part of the wonder of cardiology is the ability to have exposure and learn new things, apply new things. You know, many, especially on the interventional side, really enjoy that work and relish the opportunity to get into some new technique and new methodology that makes a difference. Some of the less adventuresome personalities prefer the imaging world, where it's more academic, cerebral, visual, certainly no risk involved with new imaging technologies. So it's the training programs, I think, are going to have ultimately maybe 2 years of general cardiology type work and then 2 years of specialty, subspecialty cardiology work, invasive tracks, non-invasive tracks, imaging, so on. That's my guess.
How are we going to train general cardiologists?
There's no such thing as a general cardiologist anymore.
Well, but there is.
No, I mean there is now, but should there be? I'll get that. Hold on, everybody.
Sure.
So the question is, should there be a continued general cardiologist
Right.
track, right?
Right.
And I think that's an easy track to extend from a 2-year general training program. The 3rd year could be continued activity in a general rotations across that. I think the heart failure specialist could become one of the generalists. Many of the imagers could continue their general cardiology work without much. I think it's hard for the structuralist, the interventionalist, the coronary guy to become a generalist because they are really taking their area of interest in a very narrow spectrum, and they want to stay in that area. There's no right now we're all generalists as well as specialists.
Right.
Right. So we do general consults. We see patients with heart failure, even though it's not my particular interest, and we manage them. And then I get help from my heart failure specialist when I have some really tough problems. So I can't envision that it's going to change rapidly, but I think with these separate initiatives to form structural heart programs, just as we formed interventional coronary programs, you'll see this division of labor occur.
Well, great. What would you like to ask me?
So, Neal, you've been one of my colleagues for this many years, and you've been in the business, and you've seen a lot of changes that have occurred. Which one or two changes have had the biggest impact on your practice that you think over the last 2 decades?
I think the availability of intracoronary stents has probably had a tremendous impact, and we think about management of coronary artery disease very differently. And I think the things we've learned about atherosclerosis have dramatically changed the way we look at people, the way we look at patients with disease, and what we tell them. We now think about changing plaque composition. Despite what one may or may not think about courage, it really has taught us that not every visually disturbing lesion needs to be revascularized. And the work with coronary physiology has confirmed that. Those are very different concepts than the ones we started out with.
Agree. So what do you make of the fact that we see fewer STEMIs in 2017, 16 and 17 than we did in 2000?
I think there are several things. I think, number one, we've trained a lot of interventionalists. So there are many more PCI programs around than were formerly available. As you know, now small hospitals have STEMI programs without having surgical backup in many locations. And I think we've changed the way we manage the disease. We use antiplatelet drugs more aggressively. we're much more aggressive about using lipid-lowering drugs. It used to be acceptable to start patients on very low doses of statins and say, oh, well, they're on a statin, we're okay. No one does that anymore. We're seeing physiologically active doses used now. So I think between the management of patients and the changing medical environment, I think those are the two big things responsible for the reduction in the number of STEMIs. And of course, as you mentioned, as a guy who carries the beeper, so often at night, it doesn't break my heart.
Right. So, last question for me. What do you think is the biggest area of activity that we're going to see in cardiology in the next decade? The single largest concentration of force?
I think that's a great question. I think on a big scale, it's going to be risk factor reduction.
Right.
I'd love to say, well, we're going to do that in the structural world, but that volume is not going to swell, in the way that risk factor interventions will.
Correct. I agree that's the case. I was, as a guy who is an interventionalist, it would be nice to say that structural heart disease is going to rise to the level of coronary disease, but it's not close.
No. Now, when people live to age 140, probably everyone will have critical aortic stenosis.
Right.
But we're not there yet.
That's good. Well, I think that gets my most pressing questions out of the way.
Great. Well, Mort, I'd really like to thank you for coming to Houston to chat with us and to visit. I hope you've got an upcoming meeting with the fellows. I hope you enjoy that, and we'll give you a tour, show you our wares.
Great. What a wonderful experience I've had today. Thanks so much.